All right. Hello, everyone. Welcome. Welcome to, I guess, the first Rafael Medina subspecialty virtual morning report. Before I jump into introducing the really exciting session we have today with three phenomenal educators, I wanted to take a moment to honor our dear friend and CPS family member, Dr. Rafael Medina. Some of you may have attended the really beautiful memorial we had for him yesterday, but he passed away last week, tragically, and this is the first morning report back since his passing. I think the team thought it would be, appropriate for the first morning report back to be one of the subspecialty episodes. And the reason for that is Rafa really helped kind of start this series and put his full force and love behind the project. Just to illustrate the impact they had. So Rafa, would just cold email specialists from around the world asking if they would join this this series. And a lot of them said yes. And basically Rafa just, with his own force and love, just provided high quality subspecialty education to learners around the world free of cost, which is just like one sliver of the impact that he did, but it just kind of shows how incredible of a person he is. And he did that all by giving other people opportunities and lifting others up. So I say all of that to say that we will continue this series in his honor. It has been renamed after him, and we will continue it with full force and love as he did. So moving into introducing the session today. So today will be an addiction medicine virtual morning report with two incredible case discussants and one of our own team members, Simone, as a case discussant. So I'm going to pass the mic now to Doctors Ayesha Appa and Dr. Soraya Azari, who will be our case discussants. So Ayesha, maybe I can pass the mic to you and then you can introduce Soraya and vice versa. So the mic is yours.
Awesome. Thank you for the popcorn. Thank you all. It is an incredible honor to be here. I think particularly to honor Rafa, and I didn't have the pleasure of knowing him, but this is just an incredible, beautiful legacy that he's created, and we hope that we do this justice today. I am very excited to be doing this with Dr. Soraya Azari. I think like my personal and professional unicorn role model. She is an associate professor in the Division of General Internal Medicine at San Francisco General Hospital and at UCSF. And of the many sort of leadership and medical education leadership roles and hats she's worn, I think the one in which I most recently interacted with her is that she's associate program director for the primary care addiction fellowship at San Francisco General. She's also been a leader in the SFPC internal medicine program, is just a phenomenal internist as well as addiction medicine specialist. And I think, like more than the hats or titles, Soraya is somebody who has taught me a lot about finding my authentic voice with patients. Like I think a lot of us go through medical training and like develop this doctor speak or voice or way we interact with patients. And she's like one of those people who, and I should say, one of the few clinicians at UCSF who's honored as a master clinician, who like really authentically like brings herself to the patients. And so I am honored to be here with you and with her today.
Wow, Ayesha, there's a little tear trickling here. That was such a beautiful introduction, and I now get to repay the favor and send all my love your way because the love is definitely mutual. Dr. Ayesha Appa is a physician who trained at the University of Washington, both doing residency training there and then a chief resident year. And she has done extensive subspecialty training. She is dual boarded, she's triple boarded in internal medicine, infectious diseases, and addiction medicine. And I had the pleasure of being her associate program director when she was a fellow, it was a clear case of her teaching me as opposed to my teaching her. She's an extraordinary educator, but she's also a researcher, and she's working in a world where we don't have enough people doing science, which is the intersection of really severe infectious diseases and substance use disorders, and how we achieve good clinical outcomes for these individuals. And if you haven't read her NEJM article about what do I do for my patient with a substance use disorder and a PICC line, sorry, that's a really bad paraphrase of the title of your article.
No, I think that's what it was.
Extremely practical, high yield article that I recommend to all of the listeners out there, because this issue comes up all the time clinically. And so I'm absolutely delighted to be here with Dr. Appa and plan on having her talk the majority of the time.
Wise. Thank you, Soraya.
Well, thank you both so much for being here. I'm really excited to learn from you both. And we have the one and only Simone, CP Solver's team member. You probably recognize her voice from all the amazing episodes, who I believe is an incoming fellow in addiction medicine. So Simone, do you want to unmute, kind of reintroduce yourself, and then we can jump into the case?
Yeah, sure. So I'm Simone. I'm a third-year family medicine resident at UCSF at San Francisco General. I will be starting my addiction fellowship at UCSF here next year with Soraya. And actually, everybody should know that before Soraya ever said hello to me, last year, the first time I ever met her, and I arrived at the recruitment happy hour, I walked in and I was very nervous, and she was just like, I just listened to you on a podcast. So it feels very good to do this episode together. I also feel like really nervous in taking up this space that is like our first time back since Rafa's passing. And I like love him and miss him, and it feels really special. I haven't been on VMR in a while, and it feels really special to be back here in this space where like I first met him and we first knew each other, and talking about something that I have been excited to make a bigger part of CP Solvers for 3 years now, addiction medicine. So I am very excited. Robbie, I'm looking at you specifically with that feedback. Okay. The one other thing I wanted to say as a caveat before I start presenting this case is one of the things I love about addiction medicine is that, as interesting as the diagnosis is, and it can be very like complex, I think it's the management of patients with addiction is equally as interesting and equally as much of an art. And so I am hoping in this case, we can really do both. We can think deeply about the diagnosis, but think just as deeply about the management and how we do that. So without further ado, I'm like a little nervous that Ayesha consulted on this patient actually when she was a fellow, but I'm hoping she didn't. A 45-year-old man. He has a history of ESRD on HD. He has active opioid use disorder. He uses intranasal fentanyl daily. He has hepatitis C with an undetectable viral load, hypothyroidism, and housing insecurity. And he is presenting with 1 day of acute back pain.
All right, so we have, this one liner here, so maybe I'll pass the mic to you, Ayesha. So we have this patient, chief concern back pain with the past medical history, and what's kind of going through your mind diagnostically at this point?
Phenomenal. I mean, what I'm hearing is someone with opioid use disorder with active fentanyl use and either treated Hep C or spontaneously cleared Hep C, who's admitted with severe enough back pain to warrant a hospital stay. I think what I'm thinking about, I think there's the diagnostic sort of world and the management world. With regards to diagnosis, I think we could consider our sort of red flag signs of or sort of etiologies of back pain. And then there is, which we can go into in a minute. And then with regards to management, I think, again, focusing on our subspecialty morning report topic, I think something that we'll think about is how are we going to effectively manage acute pain in the context of opioid use disorder, both with regards to sort of systems issues and accurately or sort of effectively treating acute pain in the context of someone with really high tolerance for opioids? How are we going to manage someone's potential opioid debt and opioid withdrawal and their opioid use disorder in the hospital? And then that sphere where sort of diagnosis and management may overlay somewhat is, how is effectively treating this person's opioid debt going to allow us to accurately diagnose the medical cause of acute back pain? And I say that, I think, to provide a concrete example, opioid withdrawal itself can manifest as aches, pains, and often folks can report back pain as a prominent symptom. Is it severe enough that it requires admission? No, not often. But if untreated, it may be easy to not to be able to distinguish that opioid withdrawal from, say, an epidural abscess or vertebral osteomyelitis that's going undiagnosed for a number of days or weeks. So I think really addressing that opioid debt and finding persistent pain, for example, can lead us down or open up the diagnostic path. I'll stop there and see what Soraya would like to add.
That was amazing. And I don't have much to add, except 2 pearls. One, now for all of you, when you're hearing the one-liner and you hear that a person has an opioid use disorder, I want the reflex to be, what medication are they on, right? So we know that medications for opioid use disorder decrease mortality by 50%. So your first question should be, is this person on medication? If not, why not? And we have to avoid that, that really negative stigma, which is that, people with drug use disorders are going to keep using drugs because they want to, right? We need to sort of frame switch and realize this is a life-threatening medical condition that's treatable. And so just like if I hear HIV, I want to know if they're on ART. When you hear opioid use disorder, I want your first thought to be, what medication are they on? That's number one. And then the second thing, Dr. Appa sort of alluded to bad causes of back pain. And obviously the sort of elephant in the room is something like osteomyelitis or vertebral discitis and epidural abscess, things that are associated with injection drug use. And so I want you to just keep in mind that if a person says that I just smoke fentanyl or I just snort a drug, you really actually want to, in a really sensitive way, ask additional history questions to find out whether or not they've also used needles, the more sort of typical risk factor for those types of infections. Because sometimes people will say I smoked fentanyl, and that refers to the past couple of days when actually, they injected last week, or somebody, a street doctor injected for them, right? So you have to be really sensitive to try and get that information. They may not want to tell you because they already feel bad about their drug use because of social stigma about this condition. So those are the only 2 pearls I'd want to make.
Amazing. Okay, I'm about to give you a lot of information, so just hold tight. And the person who's scribing, I know that I talk really quickly, so please tell me to slow down. Okay, so he was on the bus yesterday and the bus hit a pothole and he felt like it took the air out of him. He didn't fall, there was no head strikes, but ever since he hit that pothole, he's been having acute midline lumbar back pain. There's no radiation, no weakness, numbness, no bowel or bladder incontinence. He's got no fevers, but he does have subjective chills. He has a history of IV drug use, but has not used IV drugs in a year. He was in the past started on methadone many times, most recently a few months ago, but has returned to use using intranasal fentanyl and subcutaneous injection, like skin popping daily, most recently yesterday. He also uses marijuana and no stimulants. And he is open to retrying methadone or something while he's here. His vital signs, he's afebrile, blood pressures are 120s over 60s, heart rate is 107, respiratory rate is 20, and his O2 is 99%. exam, he's laying in bed and he is not in any acute distress, but he just kind of appears uncomfortable. But anytime he tries to move, he gets really, really uncomfortable and agitated. He has pinpoint pupils, his lungs are clear, his heart is normal, his belly is soft. He's got, his neuro exam is normal. And then he has tenderness to palpation over his lumbar spine with pitting edema to palpation, obscuring the bony landmarks of his lumbar spine. He can get a little agitated in the setting of pain, but is easily redirectable. And his CBC, he had a white count of 34.9, a hemoglobin of 7.8, and platelets of 280. And his BMP is normal except for creatinine of 12.2. And that's where I'll stop.
Thank you.
All right.
Oh, yeah. Sorry. Oh, go ahead, Maddie. Sorry.
No, I was going to just turn the mic to you and kind of in addition to your analysis of this, you know, Soraya at the end said, you know, kind of the initial question you want to ask is what medications is this person on? So we'd love for you to touch on kind of the medications that is on the medications used to treat opioid use disorder. Go ahead.
Love this. Yes. Fantastic. So fantastic first pass at this history. I think my reactions to I'll focus on the social history and gathering that substance use history. One pearl that I have in this realm related to addiction medicine that is really different than the way that I learned how to take a social history in medical school. And I don't know whether Soraya would agree with this. I think this can be a hot take and you can see what you think. But I think that the way that I learned how to take this history is like that we go sort of stepwise through this, you know, chief concern, HPI, past medical history, meds, social history. And then in that social history, that's where you're unpacking, you know, more about their substance use. And I think we like all think about spending a lot of that time learning everything we can, you know, the first day they come in. However, you know, this gentleman may or may not be in sort of extremis or be in like a ton of distress. It sounds like he's not acutely in distress. So you may have time to learn everything you want to know. But my pearl that I'm slowly getting to is that I think substance use histories can be management focused and iterative. And that should be something that is, you know, that all of us, and especially in patient land, should feel very comfortable with. And what I mean by that is, but management focused, you know, when you're taking care of somebody who has opioid use disorder, like Soraya alluded to, buprenorphine and methadone, you know, associated with 50% reduction in all-cause mortality, 5 times the reduction in overdose death for folks after start. So it is not only sort of a urgent, emergent thing to consider if they're interested in for their long-term survival, but also that opioid debt is going to lead to incredible suffering in the short term for that person, like when you're trying to admit them and do their med rec and like do all the practical things of getting them into the hospital. And so by taking a like management focused history, what I am alluding to is exactly what Simone shared with us. If someone is using opioids, assessing the degree or severity of their opioid withdrawal with a scale that some of you may be familiar with called COWS is one. Asking them subjectively, you know, how dope sick are you feeling, or sort of where are you in this journey is 2. And then 3 is learning more about their treatment history with regards to opioid use disorder. You know, what preferences do you have? How did you feel about methadone the last time you were on it? Would that be something you'd like us to start for you again? I think would be top of mind there. And then with regards to iterative, it's sort of getting at what Soraya had brought up at the end of our last aliquot, which I love, which is folks may not tell you everything about their use the first time you meet them, and that's okay. It may be, we did learn from Simone that he is injecting, like there is a needle going from a non-sterile space to a sterile space, bringing along lots of bacterial friends. And so that we sort of learned maybe a potential sort of mechanistic route of infection if this indeed ends up being, again, epidural abscess or vertebral osteo. But even if he had just said that, I'm snorting fentanyl or I'm smoking fentanyl, which is very common in San Francisco these days, for reasons related to stigma and feeling like, oh, I'm past injection, I can't do it. Even just remembering that someone, that there had been injection in the recent past, or I think a big unknown bucket in ID, I will say, is like the qualitative immunocompromise associated with a lot of substances that are used in the community, but both opioids, stimulants, et cetera. How do they change our sort of innate humoral cellular immunity? There's sort of a smattering of literature to suggest that they do. For example, something that people may be familiar with, community acquired pneumonia being more common, people being prescribed opioids for pain. And there's a similar literature. But so what I'll say is whether it's that someone hasn't injected or isn't able to share, you can go back and have that conversation sort of multiple times throughout the hospital stay. So I think what I am focused on right now is trying to assess the size of this person's opioid debt. And that will help me figure out what I need to do right now. And then their treatment history and learning more about sort of whether they have a buprenorphine or methadone preference will also help, again, like allow us to be management focused. I'm going to pause there. I think there's more. I didn't mention his creatinine, et cetera, but we'll see. Soraya wants to.
Totally agree. I think that my eyeballs want to look at that leukocytosis and my medicine brain is spinning. But the bigger issue is that he's not going to stay in the hospital to treat all of the things that we may find unless we treat his opioid use disorder. So my first, second, and third question are going to be about when's the last time you were on methadone? What dose did you get up to? Did you have a good effect from your methadone? Were you at a quote unquote blocking dose? That means a dose that actually blocked the high from sort of extraneous opioids. Were you seeking abstinence when you were on methadone? What are you seeking now, right? Do you want to be off of drugs or do you actually just want to spend less money on drugs? People can have all different goals when they come to addiction treatment, and we want everybody in the tent with us. And then what can I do for you right now? Do you need something short acting for your withdrawal symptoms, or can we start some methadone right now? I think that's going to help control your pain so we can find out what's going on with your back pain, right? All of those are high priorities. You don't want this person to direct their own discharge and leave before you can figure out what's going on.
And then, yeah, maybe I'll ask Maddie or Simone whether we should comment more on like the medical differential or like sort of the diagnostic aspects of the case. Do you want to keep sharing? And
I'll keep going, and don't worry about it. I'll keep filling over medical data whether or not you ask for it.
Yeah. So. Perfect.
Okay, great. So you talk to him about whether or not he wants methadone, and he's open to methadone. And so your plan is to start methadone and to control his pain with other opioids until he's on a good dose of his methadone. You get a CT scan that shows an age indeterminate L1 compression fracture with 30% height loss. And then the next day, his blood cultures grow 2 out of 2 gram-positive coccyine clusters. And he tells you that he would no longer like any imaging labs or interventions, and he's going to leave the hospital in 2 days, no matter what.
Oh man, I have like this thinking feeling that like I feel like many of us have experienced or done. I think so. Those gram-positive cocci clusters, most likely. So I'm gonna like sort of just reframe our patient for the sake of our management moving forward, and call this, I don't actually even realize or remember how old he is, but a something aged person with opioid use disorder, using fentanyl with injection behaviors, is a weird way to say it, who is presenting with likely Staph aureus bacteremia and acute onset back pain with spinal tenderness to palpation. Concerning for, say, vertebral osteo or epidural abscess. I think there were other diagnostic etiologies brought up in the chat that I think are fantastic to interrogate. But for the sake of, again, our like planning purposes, I will assume this person we know that he has a bacteremia, and I am presuming that it is going to be complicated, that Staph aureus has lodged somewhere in where he is currently tender, and started to set up shop. So I think our goals will be providing him life-saving treatment for opioid use disorder and life-saving treatment for his Staph aureus infection. What I have experienced in training and still do is that it's like very easy for us to be really worried about the Staph aureus infection and be like, we need to do everything to keep this person, or like we are only going to focus on this on the infection, when the question of like what is most immediately going to kill this person it can not be totally clear, and depending on the clinical scenario, it may be the opioid use disorder that may hasten this person's death more quickly. So I think that our goals are twofold. One, essentially to address both the opioid use disorder and the infection in this context of this person is now wanting to leave the hospital and maybe done with us. I think that to share I think I would love Soraya's input on this. I'll share the way that I think about managing this sort of case, or managing a patient-directed discharge. And again, curious what Soraya thinks. I think about it in 3 to 4 steps. I think one is it can be extremely stressful and worrisome when you like sort of have a lot left to do with this person and can cause a lot of moral distress. So I think like one sort of overarching principle is to like take a minute, try to reframe in that like this person assume positive intent, or that they are doing their best to try to take care of themselves, whatever that means for them. Not that they're trying to, wreak havoc on your management plan. And so then it's like, okay, they're trying to do right by themselves, or they're trying to do the best they can for themselves. What is that? And how might I understand this a bit more? So like one concrete thing is like, what is their reason for leaving? Are they in a place where they can talk with you through that 2 days that you have? And is there something to intervene upon? Is it undertreated withdrawal? Is it undertreated pain? The combination of the two that we can really ratchet up that short-acting opioid dose alongside the methadone that's being up titrated that Simone mentioned. And then two, is really facilitate their leaving if that's what's going to happen. Again, another like framework in which we all exist is this like inpatient medicine and outpatient medicine, but like putting ourselves in the shoes of the patient, those models don't exist. Like, they are just one person existing through the system. So as much as we can to as much as we can do to really get, say, those PO antibiotics in hand, get them one dose of long-acting lipoglycopeptide antibiotics like dalbavancin, and figure out where they'll be for that second dose. Is like arrange for clinic follow-up before they leave, things like that really facilitate them leaving in an effective way. Is I think the best we can do. And then the third thing along that practical note is just like gathering, again, anticipating leaving and trying to set up the next provider and the patient for success with like gathering contact information, whether it's a phone number, if they don't have a phone, is there an alternative contact person who will know where they are? If they don't have a home, where do they stay? What is the color of the tent that they are staying in, and where is it located in whatever city you're in? Sort of things like that outside of the box to provide, and sort of then actively providing it to their outpatient team that may be able to run into them would be, I think, my general framework. So again, like thinking about them taking care of themselves, doing their best to take care of themselves. Why are they leaving? What can we do? And then how do we facilitate it? And then I think, again, yeah, we'll sort of dive into those two conditions, I think, that need more management. Soraya,
thank you so much, Ayesha, for those pearls about patient-directed discharge. Before we move to the next aliquot, again, I wanted to see if Soraya had anything to add, but I also wanted to just kind of, we've mentioned just how kind of the life-saving abilities of methadone and buprenorphine. And I was wondering if Ayesha or Soraya, you could comment on kind of the differences in those medications and the treatment of opioid use disorder, kind of when you would use one versus the other. And also a question that's come up is when a patient tells you their previous methadone dose, do you try to confirm that from a clinic before administering? So would love for you to kind of touch on those questions before the next aliquot.
Great. So the two medicines that we talk about the most are methadone and buprenorphine. They both have this incredible effect on mortality reduction for people with opioid use disorder. There's really significant differences between them. Specifically, methadone has to be administered in an opiate treatment program, or an OTP. And for those of you that don't know, we don't have universal access to OTPs. There's one state in the United States that has no OTPs. That's actually Wyoming. And the last estimate was that about only sort of 20% of counties actually have access to an OTP. So you're really limited. And if you don't know if you have an OTP near where you live, you can actually look on the SAMHSA website. That's SAMHSA, and you can put in your zip code and actually find an opiate treatment program near you. So methadone is an incredible medicine. It's highly regulated. You have to enroll in the OTP, and in general, it is administered on a daily basis. That means you have to come to the clinic every single day to get your dose of medication. We do this for nothing else. And it's a legacy of many issues, including sort of the war on drugs, the war on people who use drugs, and various federal legislation or pieces of legislation like the Controlled Substance Act and the Harrison Narcotic Act and things like that. So that's the first point about methadone. So you can, as a resident or a hospital doctor, you can give your patient methadone. You can start them on methadone in the hospital. And generally we start somebody at 20 milligrams, make sure they're doing okay, and then go up to a max of 40 milligrams on the first day. You can continue that as long as they're in the hospital, but you cannot discharge them with methadone. You have to then send them to an OTP to enroll in that opiate treatment program. And that's where they would continue their dosing of methadone. This stands in contrast to buprenorphine, which is an office-based treatment for opioid use disorder. Now, because of the omnibus bill that just passed, every single doctor and advanced practice practitioner can prescribe buprenorphine for your patients with opioid use disorder, and you no longer need the so-called X waiver. There is obviously quite a bit more flexibility with buprenorphine, but the actual pharmacology of these two medicines is very different. Buprenorphine is a partial mu opioid receptor agonist, and methadone is a full opioid receptor agonist. And so the best way to pick a medicine for your patient is to talk to them about their experiences with both medications, if they have a predilection for one versus the other, what their lifestyle is going to look like going forward, and what kind of constraints you're dealing with. And that's how you can pick a medication. Generally speaking, when we're in the hospital, methadone is really helpful because we can start methadone and then we can give them PRN, opioid, analgesics on top of the methadone, and we don't have to worry about pesky things like precipitated withdrawal like we do with buprenorphine. So that tends to be a little bit more flexible. But that's where I will stop. I could go on and on about methadone versus buprenorphine, but I think the key pearl to get out there is that you actually can newly start a person on methadone, and you should do that while they're in the hospital. Even if they don't continue at an OTP, methadone is a great way to allow you to treat their medical disease while they're in the hospital. As to the question of verifying dose, you have to verify a person's dose. Do not give a person methadone based on what they tell you their number of milligrams is. This is just a patient safety rule, and it absolutely has to be adhered to. Also, when you call the clinic, you can find out valuable information like, oh, they're on 120 milligrams, but they actually haven't been here in 12 days, right? So you're not going to resume that patient at 120 milligrams after they've been a no-show for 12 days. So those are key questions that you want to have answered when you call the methadone clinic. Last pearl, methadone clinics close early. They tend to close right at the time that you are finished with morning rounds. I'm talking 1 o'clock. Sometimes we stay open till 2 o'clock. So before you round, you should be trying to call the methadone clinic to confirm a dose.
I love that. I should have added this in Soraya's intro, is that she is a fantastic methadone clinic doctor, and I will call her about a number of these things. Just like to also follow up on Alexander's question. One like maybe sub question that you or others might have is, it sounded like our patient hadn't been on methadone in some time. So as Soraya was mentioning, if it's been particularly particularly more than 2 weeks, like that titration you would approach as a new methadone start. And it's though helpful to understand if someone had achieved their therapeutic goal, like Soraya had said, a blocking dose at a certain number in which we're all like might shoot for if it was recent. I'd say pearl there is that if someone had been on methadone for opioid use disorder 10 years ago when they were using heroin and now they're using fentanyl in quite a different quantity, that number may not be where you end up. And so it's definitely dynamic, but can give you a sense of where you're going. Oh, and then the other thing I'll just say, Soraya is like, this is illustrated the two of them perfectly in a very sort of anecdotal way to complement what she said. I'd say that going along with, say, buprenorphine's like pretty specific mu partial agonism and methadone's full agonism with some other effects like NMDA receptor antagonism. What am I actually trying to, is it NMDA? What's the ketamine receptor? Anyway, methadone has a couple of different neurotransmitter effects. People on methadone can say like, I feel more sedated, or this is like a warm blanket. And on buprenorphine can say like, oh, I feel like the world might be a little bit more in view, or like on a knife's edge. And so there's just, like she said, a different sort of qualitative experience of those two medications. So it's just important to understand their experience with it.
I want to go into the next aliquot, but I really love Alexander's question in the chat, so I wanted to give you all space to answer the most recent question before I give you the next aliquot.
and I can just read it out loud so that everyone hears. So any pearls about what to do for a patient suffering or at risk of suffering from withdrawal symptoms if admitted at night or another time when we can't verify dosing. And then I just wanted to acknowledge to the crowd that some of the kind of bills and the regulations I just acknowledge are US centric, but that's just kind of the context here. But great question, Alex, and I'll turn it to you, Ayesha.
Such a great question. And thank you for mentioning that, Maddie. Yeah, it's so true. A lot of much of what Soraya mentioned is a sort of a US based problem. This is a phenomenal question, something that comes up often. If for folks admitted overnight with opioid use disorder, desiring methadone, either with a dose unverifiable or with a methadone start that's new, in which, like Soraya mentioned, you're going to start at a smaller dose. The reason that you are starting at a smaller dose of methadone is that it has a long half-life. 24 hours to 72 can be different in various humans. And so the day following, let's just say, call it 24 hours, the day after you take 20 milligrams of methadone, you have 10 milligrams sticking around in your system. And so if you again take 20, not even sort of imagining we're ratcheting up the dose fast, then you say like your peak level may be at 30 all of a sudden. So you can imagine that if someone said, oh, my dose is 80, and we started that right away, the next day, half of that, again, with the half-life sticking around at 40 and then get another 80, can be at a high number pretty quickly. And that's how methadone can lead to sedation and respiratory depression and badness when, again, titrated too quickly. However, that person is still really suffering, as you mentioned, related to their opioid debt. So I think the way that I approach that is starting the methadone at that dose of 20 to 40 on day one, and then using short-acting opioid agonists to make up the opioid debt. And I cannot tell you how many times I've said, I wish there is a thermometer for opioid tolerance that would let us know the exact dose of, say, PO oxycodone or IV hydromorphone that we should use right off the bat, but I don't have that thermometer unless Soraya does, and she can share this afterward. So what I end up doing is, again, have that methadone there for base that's going to slowly increase over the next number of days. And then your short-acting medications will be a little bit of trial and error. I think the things to consider are, one, this person has considerable increased tolerance for opioids given their fentanyl use, which is, hugely potent in changing their tolerance, expanding it by quite a bit. Two, there's some data to suggest that people with opioid use disorder may have just dysregulated receptors, perception of pain, et cetera, that leads to lower pain tolerance. So folks are just going to have a ton of pain and they'll be tough to manage, in addition to, again, this withdrawal debt. So the way that I've practically do this is using some higher dose of oxycodone and IV hydromorphone. If someone's saying I use a gram of fentanyl a day, I may start with something like 30 milligrams of oxycodone, PRN, signs of opioid withdrawal or cravings, Q 4 hours, again, PRN, and a milligram of IV hydromorphone, same PRN. But again, the key step is reassessment. I think if those numbers sound high and scary, it's because they can be for someone who's opioid naive. So I think a strategy is always assessing your patient at the peak of whatever dose that you are sort of adjusting to. So if that is, say, your PO oxycodone, see them an hour later. If that was something that you were like, I'm not sure if this was too little or too much. If you see them at peak and they have, are sweating, writhing, anxious, completely dilated pupils, that person is not only sort of over medicated related to your opioids, they're in withdrawal. So like you can keep going or up titrate or give them another dose. And vice versa, if you see them and someone is sleepy or has pinpoint pupils, that's a sign that you should back off. So I think that, again, I'd say approach in summary to addressing this, like, what do I do overnight, is get that long-acting methadone on in the background, and then use short-acting opioids with frequent reassessment at peak to define whether or not you are sort of at therapeutic goal or seeing any signs of toxicity.
Amazing, thank you. Okay, I am going to give you the next aliquot. So the next 3 days go by, the patient's withdrawal is well managed. You're up titrating his methadone. He feels good on how much Dilaudid and oxycodone he's getting. He's comfortable. He's got good rapport. Comes to hospital day 4. He says, I got to leave in an hour to take care of things. No, I'm not in withdrawal. No, I'm not in pain. I need to go take care of things. He said, I promise, I'll come back. And when I come back, I'll get that MRI that you so badly want me to get. And you're like, all right, that sounds good. And then you are about to place the discharge order when his nurse reminds you that he has his temporary hemodialysis line in place because his tidal line catheter had to be pulled when he first came in because he was infected and there was pus found on the initial line. And so the nurse pages you to say, what do you want me to do with this tunneled line?
Oh man. Another like, yes, nice twist, Simone, the tunneled line. I think that I wish I could hear what other people are thinking at this moment. But
this to you. Every time he misses dialysis, he goes into PEA arrest because of how high his potassium goes.
Oh God. This does actually sound like someone I was just consulting on. Oh God. So I think Simone has elegantly shared with us that we are concerned about a number of life-limiting sort of must manage urgently conditions. We've talked about his opioid use disorder. We have talked about a complicated, most likely Staph aureus bacteremia and ESRD we have on the list too. I think, as Soraya mentioned at the introduction, I think like part of this part of like the writing I've done the last couple of years is like acknowledging the angst and worry the moral distress we all feel, and like, what do we do with the line? And so want to name that we are all here to like take the best care of our patients possible. And I think that what is wrapped up in that is like worry that this person is going to use through the line, or it'll be a facilitator of ongoing use and or potential sort of, again, another opportunity for bacterial introduction. Like I hold that and like call it out, and then also sort of call out the things on the other side of the seesaw, or whatever analogy you want to include there, which is, Simone just said, that this line is necessary for him to keep living, without hyperkalemia. And we also have an opportunity for treatment of his infection via this line is also something that we haven't, we'll hopefully hear more about where our diagnostics went, but providing vancomycin at dialysis is, and again, in hopes that with hope that he comes to dialysis, is another potential effective strategy. And so I think like the way that I approach this would be having a frank and open conversation with the patient. Practically, it sounds like you may have to figure out how much time you have to have this. But I think that what it may feel like an uncomfortable conversation, like I'm calling someone out for potentially using, or I'm making assumptions about them using through the line. When in reality, I think that it can be an open dialogue, and your patient may have and likely do have many things to like teach you back about how they use and what they know about injection hygiene, et cetera. And so I think that again, the way that I would approach this is leaning toward, I think from a management perspective, keeping the line and having a harm reduction conversation with this person about how they're using. So I would start by sort of the same ask, tell, ask framework that we use in sort of the medical teaching setting, and asking them, what they know or think about their line and its risk of infection. And then I would ask them, like, tell me how you use and how you prefer to use. And then depending on where this conversation gets you, I think include some teaching around ideally minimizing or not using the line for use. It sounds like he's reporting largely intranasal use and some skin popping. And so while I think that there's a hierarchy there, and I would put skin popping below intranasal use, I'd put like the use of the tunneled line below skin popping. So I think like having that explicit conversation is important. And then also talking with them about how and where they're accessing supplies for safer use. It would be a part of that too. Soraya, what thoughts do you have?
I agree with all that. I think that all of us are harm reductionists, right? Harm reduction is radical love, right? So we love our patients. We want to see them do as good as they possibly can. Is that always perfect? No, it's not, right? And so we see a lot of sad things or things that don't go the way we expect them to. And we have to also respect that person's autonomy, that they're making the best decision for themselves. I do always like sort of lead with love and find out the reasons for wanting to leave, because sometimes they have to do with medications. I will tell you, in my many years of clinical experience, it is much more common that it has to do with real life stressors. Like nobody is watching my dog. Like my dog is not eating food right now, or I will get evicted if I don't pay my rent. I need to go pick up my income that I get on a monthly basis. I owe this person money. I have this court case to appear for. Every time I always hear there's my patient stories, and I'm like, that's a really good reason to leave the hospital. So we have to work around that. And all the ideas that Ayesha brought up are the ones that I would be entertaining to come up with a solution that works for that person, albeit it may not be the plan that the medical team thinks is best.
So he needs to pick up his income, and he goes and picks up his income, and then he comes back like he said he would, actually later that afternoon, and gets the MRI as promised. The MRI shows osteomyelitis discitis of C5, C6. You astutely get imaging of every part of his body, and he has osteo of his C-spine, his left glenohumeral joint, he has a left septic shoulder, et cetera, et cetera. And over the course of many, many, many weeks, he has all those sites washed out, and he gets source control and is discharged to respite to complete 6 weeks of IV antibiotics. And he is ultimately up titrated to 100 milligrams of methadone, and he remains at respite for at least several months. And that is the end.
That was beautiful, Simone. I love also like the words out of Soraya's mouth, and then this happened. Totally second what Soraya said around, like, it can feel very, again, when we're like in our inpatient with like using our inpatient medical brains, like picking up a rent check, like what, how is this possible that someone needs to go do or like interrupt this treatment, and yet this is life sustaining. I think like seeing on the flip side someone who had left San Francisco General after having had a septic knee that had not been washed out, but because he had been told that his tent and like all of his belongings were going to be cleared the next day, was like, oh, of course, like this is the roof over your head and this is your existence. And like, and so that is, I appreciate you sharing that story.
I also want to leave one last pearl with everyone, which is when this person left the first time, don't make them an AMA discharge. Just discharge them like everybody else, right? And wait for them to come back, right? And Dr. Appa has also published on this. I'll put this in the chat, right? When people that direct their own discharge, they are at really high risk for readmission and sort of adverse outcomes. And so you want to be treating that person like the VIP that they are, right? You want to be like, I don't know, promising them ice cream when they come back, just whatever you can do to have them come back, to get them well. This is a person that's really sick. And so this is where, you know, medicine is both science and art. The art of medicine involves our relationships with patients. You need to build a positive relationship with this person so they'll trust you enough to come back to the hospital and get well. And so the way to engender trust is to not make them feel like a patient criminal by calling them an AMA discharge, right? It's a person that just had to be discharged from the hospital, and then they'll come back. So great work by whomever the team was that took care of this patient, that they came back and no surprise took care of all their acute conditions.
Love that.
Yeah, and Ayesha, I just wanted to turn it to you to see if you had any last kind of teaching points you wanted to highlight before we end this session.
So many fantastic things that Simone raised and that Soraya talked about, and that, like, just an incredible chat too. I think that I will share two pearls. One, I think when thinking about that approach to the formerly AMA discharge or the patient-directed discharge, again, encourage people to, one, assume that the patient is taking their best job, doing their best job taking care of themselves, assume positive intent. And with that, try to explore and figure out what their reason is for leaving, to see if there is something modifiable to try to help them stay. Primarily, something we see a ton, undertreated withdrawal and pain. And then two, really do a good job facilitating their leaving and trying to make that inpatient to outpatient transition as seamless as possible by doing very practical things like meds in hand, getting that phone number or location that they're staying. And then two, I think that just coming back to something Soraya said I loved, which is, if you're putting opioid use disorder in your one-liner, what is their status with one of our life-saving medications for OUD, buprenorphine or methadone? Are they on treatment, and what can we do to get that person on treatment? I think that's super huge. And you know, we talked about the distinction between methadone and bupe and a lot of those pearls, but I'll leave those, I think, to the teaching points that are written, which are awesome.
Well, thank you so much, Ayesha and Soraya, for your really incredible teaching. Soraya, I think you described very well, like, just, I think you both highlighted kind of the art kind of hand in hand with the science of this. And I personally am going to kind of take a lot of these pearls to heart in the future, and really appreciate you both for your incredible teaching during this session. And Simone, thank you so much for bringing this case. Really, really appreciate it. And Simone, did you have any kind of last words before we end the session?
No, it's I have taken care of this patient and many patients like him so many times, and it's still so wonderful to hear like new people's thoughts and approaches to it. And I really love learning from both of you. So thanks, guys.
Awesome. Well, we will end the session there. Thank you all so much, and we'll see you at the next one.
Bye, everyone. Thanks for having us.
Bye.
Take care, everyone.